Good afternoon, everyone. Dear participants, dear organizers, dear chairs, I would like to present you our more than a decade of experience with intraoperative neurophysiological monitoring in epilepsy surgery in the Department of Neurosurgery, University Hospital St. Ivan Rilski, Sofia, Bulgaria. Epilepsy surgery has some specifics. First of all, it's a kind of functional neurosurgery, and as such, we have very low tolerance to neurological deficit. As you know, most patients in epilepsy surgery are neurologically intact, and they should stay like this. So one very important thing in this particular setting is that neurological deficit is highly undesired, let's say. Not that it's desired in other parts, but it's another thing is that maximum resection of the seizure onset zone is related, there are a lot of papers about this, with better seizure outcome. So the more you remove, the better the seizure outcome is. In many cases, we have no clear lesion, so these are the so-called non-lesional cases. In those cases, we very frequently have to remove until we reach a certain function, which is our limit of resection. And even if we have a visible lesion, very frequently the seizure onset zone is larger than the lesion itself. So again, we can be forced to reach functional limits. Those patients are usually of young age, frequently children, and this has some very important consequences in terms of choosing the way of monitoring, whether to be awake or under general anesthesia. Intraoperative monitoring has uses a lot of techniques, but it has two main purposes in the OR. Well, first one is focused on mapping. So the first purpose is finding a specific, the substrate, the anatomical substrate of a specific function. The other is continuous monitoring, the so-called continuous monitoring, which has the purpose of continuously or intermittently during surgery to assess the integrity of certain function. So while we remove cortex or subcortical structures to be sure that we are not harming certain function. We have recently published this paper. It's called Awake Epilepsy Surgery in Patients with Focal Cortical Dysplasia. It's published in World Neurosurgery. In that paper, we compare awake surgery patients with two control groups, one with neuromonitoring in general anesthesia and one with no neurophysiological monitoring at all. We'll come back to this paper later. Awake craniotomy is one of the most frequently used options for intraoperative mapping in surgery in general. So the technique is described by the famous Wilder Penfield in the year 1937. Well, when he described the famous motor and sensory homunculi, he was the first to map motor and sensory structures and to describe those. Later, the technique is widely used after the late 1980s by several famous authors mostly in glioma surgery. In modern epilepsy surgery, in my opinion, it's relatively rarely used, at least relatively rarely described in the literature. Our experience with it is extensive. We have more than 200 procedures in general and more than 30 of those in epilepsy surgery. Our way of doing awake craniotomy is shown here. We perform the so-called sleep-awake asleep technique. So the patient is introduced in general anesthesia with laryngeal mask, and the craniotomy and urotomy are done. Then he is awakened for functional mapping and resection, and after that put asleep again. With no intubation, just sedation, while we use local anesthesia to anesthetize the scalp. The usual way of stimulation with awake is low frequency stimulation, 50 Hertz, the so-called Penfield technique with bipolar probe. We can map a lot of things with awake. We can map motor function, so-called positive, negative motor zones. We can map speech, different speech representations. We can as well map somatosensory and visual cortex representations. This is the simplest case of mapping motor and somatosensory cortices. In this case, we have the right frontoparietal area exposed, the right central region exposed. This is a case of focal cortical dysplasia. You may see that this patient underwent stereo EEG. Here are the scars from SEG electrodes. Here as well. And you see the different positions of the probe that we stimulated the exposed cortex with. In this case, we prefer to use awake craniotomy because the intended resection was this portion of frontoparietal operculum, which corresponds to the lateral parts of the precentral, postcentral gyri, responsible for motor and sensory function of the face, and this posterior part of the inferior frontal gyrus. This is stimulation of the lateral part of the precentral gyrus. You see movements of the left part of the face twitching caused by stimulation at that point. You see stimulation of the distal hand area, which provokes flexion of index finger and middle finger. So here is the representation of the distal hand mapped. As I told you, in this case, we needed very reliable monitoring because the intended resection was this. So this is the resected facial area of the precentral and postcentral gyri. Of course, we spared the arteries that go to the other parts of the paracentral structures. this patient had some transient deficit for the face muscles, but he was neurologically intact 4 weeks after surgery, so no neurological deficit on the long term. This is another case of awake. In this case of focal cortical dysplasia in the left inferior frontal gyrus, we perform speech mapping. Well, this is the simplest task. It's patient is asked to count speech generation, and we are looking for speech arrests from the frontal speech area of Broca. Here on the left is surgeon site of surgery, and the patient which is awake and doing the task. This is the same patient performing another speech task, which is object naming. So the patient is asked to name some common objects which are shown on a screen in front of her. And the surgeon is giving a signal for introduction of the stimulus of the object and simultaneous introduction of the stimulation. It's very important. This way we usually map the temporal speech area of Wernicke and the tract. Awake craniotomy has some very important advantages. Of course, there are quite a lot of disadvantages with this technique. Well, the most important thing is that it could be used for a wide spectrum of functional mapping, except for motor mapping. We can use it for speech, for sensory, for visual cortices. It's easy to interpret monitoring results when you ask the patient to move his extremities, when you perform a conversation with it, not you, but the neuropsychologist, let's say. You are constantly able to monitor the integrity of functioning, neurological functioning. Disadvantages are that cooperation from patient side is needed, which is the reason it's not applicable in small children, and even in some adults. Well, it's difficult to perform it when the function of interest is not intact. If the patient has, let's say, a speech deficit, if he has aphasia, you cannot map this function. It takes longer to perform awake surgery. You need a lot of experienced specialists in the OR. You need anesthesiologist who's aware of the procedure, neurophysiologist, neuropsychologist, and something important, it has a relatively high intraoperative seizure rate. About 25% of surgeries, in 25% of cases, we have intraoperative provoked by stimulation seizures. This could be even more in the setting of epilepsy surgery. In the cases in which awake is not an option, and in cases of non-dominant localization of the process and the intended surgery, we have a lot of options for monitoring under general anesthesia. The most important one is cortical mapping cortical motor mapping with motor evoked potentials on the Anastasia. This is a technique described by Taniguchi and others in the year 1993. It's performed under total intravenous anesthesia, usually with continuous infusion of propofol and fentanyl. Muscle relaxants should be avoided. It's based on monopolar stimulation, the so-called short train technique, usually trains of 5 to 7 stimuli. For cortical stimulation, it's a nodal stimulation. For subcortical, it's cathodal. We record motor evoked potentials from contralateral extremities and face muscles. We have big experience with this technique. Also, more than 250 procedures in general, and at least 30 of those cases are in epilepsy surgery. You see here right-sided focal cortical dysplasia, which is mapped by monopolar cortical mapping. Here is the motor strip, the precentral gyrus, the already mapped precentral gyrus. And here are the motor responses recorded by machine for intraoperative monitoring. So you see here responses from the tender muscles elicited by stimulation of this zone of the central gyrus. Here, this zone, the lateral part of the precentral gyrus, provokes facial responses, which are seen here. And on the right, you may see that we have made the cortical incision just in front of the precentral sulcus. So after mapping of the central region, we have made this incision and removed and blocked this focal cortical dysplasia. Subcortical mapping is rarely used in epilepsy surgery. It's mainly because we remove cortex in epilepsy surgery. The idea here is, this is a tumor case I'm showing you. The idea here is that in different stages of resection, we may acquire semi-quantitative information about the proximity of the pyramidal tract of the corticospinal tract by stimulating different parts of the field. So at this point of surgery, we have reached 40 milliamps. Here we have reached 7, and the final part of the resection, we have even reached 5 milliamps, which corresponds to a distance of about 5 millimeters from the pyramidal tract. As I told you, we rarely use it. This is one case in which we have used subcortical mapping, although I'm showing cortical mapping here on the slide. But this is a very interesting surgery. It's the so-called everything but motor hemispherotomy. So we deconnect one of the hemispheres, in this case the left one, all of it except for the precentral, postcentral gyri and their projections, the corticospinal tract and the thalamocortical pathway. And in this case, we would stimulate in the depth of this incision, of this deconnection, to check for the proximity of the pyramidal tract and to stay away from it in order not to cause a deficit by interrupting it. Continuous monitoring. This is again a tumoral case that I show you, but the concept is that we are comparing baseline responses, baseline MEP responses with the ones during resection and the final MEPs, and this way we can continuously assess the integrity of neurological functioning. Here is well, you can perform continuous monitoring with the probe. The surgeon is placing the probe in the same location where he was where he has previously localized the precentral gyrus, the motor responses from certain body part. So in this case of cavernous angioma, which had bled, we check the integrity of the pyramidal tract and the respective cortex at different parts of surgery. Although very useful and important, MEP-based modalities are not always possible to be obtained, especially in very young children. We have a failure rate of about 50% to obtain MEPs in children younger than 5 years. In those cases, of course, awake craniotomy is not an option. So we have the only available option for intraoperative mapping of the central region in that cases is the so-called cortical SEPs, somatosensory evoked potentials. This is a method again introduced in epilepsy surgery, in the field of epilepsy surgery by Goldring in the year 1978. It's a technique for mapping the central sulcus itself, not the primary motor cortex. It uses contralateral median nerve stimulation usually, although tibial nerve stimulation and trigeminal stimulation are possible. It is based on the reversal of the initial components of cortical SEPs N20, P25 on both parts, on both sides of the central sulcus. So you have N20 on the postcentral structures, and you have the mirror, the negative P'20 image on the frontal side of the central sulcus. This is again a case of left-sided focal cortical dysplasia, a very large focal cortical dysplasia. It engages most of the frontal lobe, but as well parts of the precentral gyrus, the lateral part of the precentral gyrus. This is a case of 3-year-old child, and in this case we had no other options for mapping of the central region. Mapping with MEPs was not possible, although very high thresholds for mapping were used, up to 30 milliamps. So we used this SEP phase reversal technique. This is a strip electrode of 4 contacts. You may have larger strips, and you may even use grids. And you see the typical parietal recordings, N20, P25, here and here on first 2 contacts. But between second and third contacts, phase reversal happens. So this is the mirror image of the N20 and P25 waves. So we may say in this case that we have phase reversal between second and third contact. When we move the strip electrode medially and laterally by 1 or 2 centimeters, we may simulate the effect of a grid electrode. So we may map the central sulcus from, let's say, here to down to here. So this was the only available option for mapping in this case, and we have performed resection up until here. Neuromonitoring under general anesthesia has some important advantages. Unlike awake craniotomy, it's applicable in all ages. It's faster than awake. There is no discomfort for the patient, so it can be used in all age groups, in all levels of intelligence and cognition. Intraoperative seizures are much less frequent. In some published series, they're not even documented. So some say that they don't have intraoperative seizures with these techniques. We have some, but they're less than, much less than with awake. And even if you have intraoperative seizures, they're milder and easier to handle. And almost instantly, you are able to continue monitoring and mapping. Disadvantages of the technique is that those techniques are mainly for motor mapping, and you may only indirectly use them for other structures by their relations to the motor cortex. And monitoring is a bit subjective. In awake, we compare, we evaluate the function continuously by asking the patient to move his extremities, to talk with the neuropsychologist. So it's a very direct way of assessment of the integrity of the function. With monitoring under general anesthesia, it's comparing waveforms, which could be more difficult and, as I said, subjective in terms of interpretation. This is a table from the paper that I have showed you in the beginning. It summarizes our experience with surgery for focal cortical dysplasia. So our series consists of 95 cases in general. In the awake craniotomy group, 14 patients. In the intraoperative monitoring with general anesthesia, 16 cases, and general anesthesia without monitoring, it's 65 cases. So about 1/3 of our patients with focal cortical dysplasia were subjected to some kind of intraoperative neurophysiological mapping and monitoring. Awake patients were about 10 years older on average than the other two groups, which difference is statistically significant. Site of surgery was again predominant on the left side with awake surgery. So 85% of cases of awake craniotomies were with left-sided lesions, which difference was statistically significant. And something important, in those two groups, first and second, with functional mapping, we have 3 transient postoperative deficits, but no permanent motor deficit. So this means that in those cases of mostly eloquently localized lesions, we have some about 20% rate of transient neurological deficit, but fortunately we don't have any permanent neurological deficit, which makes us speculate that we have the same functional outcome in highly eloquent lesions than we have with non-eloquent lesions, like with group 3. And this difference is due to functional mapping. And something very important is that seizure outcome measured by the mean angle class has no statistically significant difference between the three groups, it's even smallest if you consider it like number in awake craniotomy. Of course, those differences are highly insignificant. So, in conclusion, I would like to stress that intraoperative monitoring techniques are safe and reliable. And in our hands, we have only had some intraoperative seizures as a side effect, which are easy usually to control with cold saline irrigation with no further consequences and complications. Those techniques allow us to perform maximal safe resection in eloquent brain areas, and a bit of an exaggeration, but they help us to operate in eloquent brain regions like we are in non-eloquent ones. Thank you very much for your attention.